Hello, everyone. I'm Richard Nahas, and it's a pleasure to join you this evening. I am sharing my screen, and let's dive right in. I call this presentation Beyond the Scar because I thought Star Trek was a little too cheesy. The message for this presentation is how treating blockages, an approach that I call blockage-based care, as lesions that medicine forgot, can improve surgical outcomes. But this message is relevant to many other aspects of medicine and healthcare. So it's a pleasure to dive in with a story, as we often do. This is a real patient, not his real name or his picture, but the Monday morning after my first neural therapy workshop, I saw this gentleman who I had seen a few times before, who had chronic low back pain that began shortly after prostate surgery. He had an incision on his abdomen. And he saw me 7 years and 7 drugs later. And I had been treating the areas where he had pain with injections, because that was the nature of my practice and still is. And then on this visit, I decided to treat the scar. So I treated his abdominal scar, and when I saw him again in follow-up, he surprised me by telling me that he had a very dramatic response. His pain was significantly reduced, but it was completely gone for 3 weeks. Treated him one more time, and then I didn't see him until Christmas, when I got a basket that looked just like this. And this gentleman is still pain-free. So this is not what neural therapy can do in every case, but it's a case that illustrates a really dramatic potential to improve outcomes. So the incidence of chronic pain at 12 months after, these are 20 of the most common surgical procedures that we do. Very high risk after limb amputation, as you can imagine. Anything in the chest, thoracotomy, sternotomy, breast surgery, quite high risk of pain. Hernia repair, gallbladder, either open or laparoscopic, C-section, major abdominal surgery, bariatric surgery, all around the 10 to 30% range. And then you have the orthopedic procedures, total knee, total hip, lumbar spine, anywhere from 10 to 40%. So regardless of which surgical discipline you're in, if you're a surgeon, you're dealing with patients who have persistent pain after surgery. Just as an example of what I would consider in a patient who has pain after hip arthroplasty. Obviously, there are lots of complications that can occur in and around the prosthesis, in and around the joint, fractures associated with the loosening of the prosthesis, growth of bone and tissue. And so, ruling out all of these other causes is part of the evaluation. But there are a certain percentage of people, between 10 and 20%, who, in spite of what seems to be a successful procedure, still have limitations affecting walking and daily function. And it's a little higher for knees, as you can imagine, because it's a more mobile joint. So this is sort of like a lens of the problem. This is, across the board, surgery is an excellent thing to do in most cases. In Canada, we're quite conservative in terms of who we operate on. In the US, it's much more dependent on reimbursement and other factors. But I'm coming from the perspective that there's a new way to think about how the body functions, how the body moves, how the body gets broken, and how the body can heal through this lens called neural therapy. And you might consider it a renaissance in medicine because it's the rebirth of a very old idea. So, the Renaissance was first used by a historian in Switzerland. It describes a period when, beginning in Florence and then spreading through to the rest of Western Europe, they rediscovered old classics and started examining and questioning the dogmas and the known way of doing things. And just inspired by that concept, I'll just summarize the current medical paradigm that we learn in medical school. The concept that each disease is a unique entity. And we define these as diagnoses, and we categorize them by body system or by disease type. And we have hundreds of different diagnoses. They're based on symptoms, signs, test results, imaging studies. But many of the chronic diseases that we treat are what we would call multifactorial. And the way we decide how to treat a person now is if there are double-blind studies suggesting that everyone with the condition as a whole did better on the drug than on a placebo, then or with a treatment than with a placebo, if it's a surgical procedure or a physical therapy maneuver, whatever it may be, then everyone with the diagnosis should receive the treatment. And it implies that everyone with a diagnosis has it for the same reason. And it also implies that a single thing can only cause one disease, when in fact, it's a lot messier. And in most cases, we're not really looking to restore the body to normal. We're looking to improve outcomes, like how long you live, or how likely you are to have an illness recur, or what your function or quality of life is, which are, valuable goals. But what if real healing is possible? So enter this concept, which I didn't invent, but some of the language and some of the aspects of this that I'm bringing together, I think have been brought together for the first time. So the blockage hypothesis is based on a very simple idea that any injury, trauma, or traumatic event can create a scar, a hidden lesion where restrictions in connective tissue, scars in fascia, and sensitized nerves can persist. And the net effect that these lesions have on the body results in tension, inflammation, and stress. It seems through years of careful observation, and this has been confirmed by many colleagues, a really great subject for investigation, that these lesions can be identified using light touch. There are areas where light touch can elicit a subtle but clear, palpable, reproducible skin reaction. And the notion that these points of tension in the body pull and tug on each other, distorting the alignment of long chains of fascia, has revealed a very important structural blueprint for how the body is built, how all our parts connect, and how they move as sections and units. And of course, it states that treating these lesions will help the body heal itself. It will turn off the disturbances that they were creating, allowing the body's normal systems to restore the innate healing power of the body, as it were. So the notion that our scars might be worth treating has been prevalent in all of the world's healing traditions. It's curiously absent in Western medicine, except for neural therapy, which was developed by this pair of doctors, the Hunicki brothers, one doctor, one dentist, at a time when Procaine or Novocaine was the only local anesthetic that was commercially available, and it was widely used to treat pain. Remember, this was before the era of pharmaceutical drugs. Oral medications were largely a cottage industry. The science of pharmacology was in its early stages. So injecting painful areas was common. And these physicians were the first to identify scars as lesions worth injecting. And they taught neural therapy in Germany and later throughout Europe, and eventually into Latin America, into about 30 different countries worldwide. So the term they use is Störfeld, which means interference field or disturbance field. And it refers to an electrical field of noise around irritable sympathetic nerves in areas where previous trauma has made them sensitive. And so the fact that the sympathetic nervous system controls blood supply, tissue tension, lymphatic drainage, and fluid flow led to the notion that injecting Procaine into these areas not only turned off the nerves, but restored normal fluid physiology, cardiovascular function in the region, lymphatic drainage, improving nutrient delivery and the elimination of wastes, improving cellular health, and with a period of time when the noise is turned off, the body regains equilibrium, essentially, which is what a healthy body is supposed to do. So, as the president of NANT, the North American Academy of Neural Therapy, my mandate is to create awareness of neural therapy among my English-speaking colleagues, both in medicine and in the other health disciplines that are allied with medicine and that often end up treating a lot of these problems that medicine finds challenging. So rehabilitation providers, integrative healthcare providers, doctors doing pain management, doctors doing acupuncture, functional medicine. But in addition to that, I think if these really are lesions, I don't want this to be a wellness therapy. I want this to be a historic medical advance, because it's either true or it's false. And if it's true, it's a big deal. So while there are tens of thousands of doctors worldwide in other countries doing neural therapy, my mandate is to collaborate with them to create awareness here. But I have a vision that integrates manual medicine providers as essential players in any healthcare solution here. And that's great because these lesions include fascia. And so if you think about how significant the germ theory was in changing the way we think about how we get sick and how we get well, in terms of changing not just the landscape of healthcare, but human history, uh, it would be a beautiful world indeed if treating our scars made a difference. I'm going to skip over this, but what's leading me down this road is a notion that this lesion is not just a lesion in the nervous system, which is what neural therapy is based on, using freezing, a local anesthetic, to turn off nerves, suggesting that nerves are the problem. And this is a schematic of the autonomic nervous system, which, as we know it, regulates the shift between rest and vigilance, between stress and homeostasis, reacting to an external stimulus in the world around you versus restoring balance in the internal milieu within you. And the autonomic nervous system is just the tip of the iceberg. We now recognize this to be just sort of like the conductor in a symphony of musicians that modulate the flow of stress and release in multiple systems of the body. So what I call the pine system is a modification of what many researchers are studying in a field called psychoneuroimmunology. What that means is that our thoughts and emotions and the function of our nervous system and our immune system, to which I've added the endocrine system because hormones are intimately linked to this. All of these cells and receptors and transmitters and molecules talk to each other. There are neurotransmitters on immune cells and there are antibodies on neurons and hormones to regulate function, growth, and development throughout life. So when I do neural therapy, I also consider fascia as part of the lesion. And what I teach is how to find those lesions using touch. And my vision is that when you know how to feel them, whether you're an injector or a manual medicine provider, you can target the lesions that matter most in each patient. And here's why fascia is so fascinating and such an integral part of this story. So fascia is primarily made of type 1 collagen. It's the most abundant molecule in the body. It's wrapped around and woven into all of your parts, your bones, your muscles, your ligaments, your organs, your glands. It doesn't just hold them together. It's literally the matrix that they grew out of. So they're all attached to this carpet that you're woven into. And we know now that fascial fibers, when they're scarred and growing in abnormal pathways and directions, can sometimes wrap around and strangulate peripheral nerves. And we know that cerebrospinal fluid actually flows through peripheral nerves. So fascia can choke tiny little nerve fibrils, not the ones that have names, the large branches of the tree, but the tiny, tiny nerve fibrils that don't have names, closer to where the leaves are in the tree. The free nerve endings, the nociceptors, can be choked and strangled by scar tissue in fascia. We also know that fascia is very richly innervated. This comes from immunohistochemistry studies that isolate and identify different types of nerves and actually count them. And it seems that superficial fascia is second only to skin in terms of the density of nerves. And most of the nerve fibers are at the place where fascia connects to muscle. So fascia and muscle talking to each other, sensing each other. And all of these are free nerve endings, which is where pain fibers live. And in areas where you've had scar tissue, there are more free nerve endings. The density is increased in the places where you're wounded. And there's a group of sensory receptors that have just been detected called piezo receptors. A Nobel Prize was awarded for their discovery a few years ago. And these receptors are present not just in humans or animals, but they're present in all living things. Plants, protists, worms, insects. One of the oldest molecules in the living world. And so there's one variant in the neurons in the dorsal root ganglia and the trigeminal ganglia for the doctors who know these names. But there's another variant that mediates light touch, proprioception, and vibration sense. That's important because it suggests that detecting vibration and reacting to subtle changes in vibration is really fundamental to life. So, you know, fascia is richly innervated. Fascia can choke nerves. We can detect vibration. Where's he going with this? Well, it turns out that collagen is a molecule that is piezoelectric. This is based on studies done in Japan in the 50s and 60s. It's not disputed. What that means is that the electrical impulses of nerves make fascia hum. They make collagen fibers vibrate. So this is because crystals that have a certain atomic arrangement where repeating units that share electrons can transmit current, lead them to build up charge under pressure. So mechanical force creates electrical charge, and electrical fields create mechanical waves. And that's why quartz has been used in many technological applications. At first, natural quartz, and now synthetic quartz is used in most of the technology around us. And the reason is that at the molecular level, when you make collagen in a cell, you start with 3 fibers, you weave them into a triple helix, you snip off the ends, and then you stack them like a bricklayer in regular, repeated, diagonal arrays separated by precise distances. So that's a regular repeating crystalline unit, and that's why fascia is piezoelectric. And that's why the electricity in your nervous system creates vibration in tissue. So all of this science about piezoelectricity of collagen turning electrical impulses in nerves into vibration, which is palpable thanks to piezoreceptors, is the physiologic basis for what we can feel. And the kind of feeling that I'm suggesting is something between the picture at the top and the picture at the bottom. What I do in my clinical practice is not hover over patients' bodies, although if what you're feeling for is subtle vibrational fields and you have sensory receptors in your fingertips, there's no reason why you would not detect a change in the oscillations in one area over a scar compared to another. But what I do is I use very light touch, and I look for an area where there's a palpable reaction in skin. And that's very concrete and abstract. And I look forward to doing the research on inter and intra-rater variability. But my anecdotal experience is that people can learn to do it in a day in most cases. It's reproducible. And the places where people have these lesions is consistent over time. So what do they feel like? Not so important, because we all interpret sensation with different words. What matters is that you're detecting a palpable change in what you feel here versus what you feel elsewhere. That's what tells you that you're on a spot where there is what I call a blockage. So I teach a systematic approach to touch. I teach providers to assess entire myofascial chains from spine to tip. We use muscle contraction or gravity or a weight to create tension in the change, because when it's engaged, the difference between normal and abnormal is more clear. We can use the entire hand to scan long tracts of skin to identify areas where we feel something. And then we can use 1 to 2 fingers to more precisely localize areas. And sometimes it's a stroke, but sometimes it can be a tap. So if scar tissue in fascia is palpable because we can perceive vibration, and the areas where nerves are sensitive are firing differently, and this allows us to detect the Störfeld in the autonomic nerves that we treat with neural therapy, then we conclude that fascia is part of the nervous system. So I'm going to go back to the Renaissance because I was inspired by Michelangelo's approach. I'm humbled by his talent, but and his effort. What he did with the Sistine Chapel in his 70s is incredible. Anyway, this is an iconic painting because of the fingers that are reaching for God in Adam's hand. And I think that the real insight from this work of art is not in the fingertips at all, but rather in his portrayal of the long chains of fascia that create lines in the body that mimic the acupuncture channels that were described in China thousands of years ago. This is what would be called the gallbladder meridian. And when you see it, you can't really unsee it. It's very clear that he was aware that these lines existed and that this contour was a part of how the human body was built. So interestingly, the story is that Michelangelo was taken in by a priest at the Basilica di Santo Spirito in Florence because of his artistic talent. At the time, dissection of corpses was prohibited, but Michelangelo kind of struck a deal with the priest, and he was allowed to dissect the corpses in exchange for producing this crucifix, which is still on the wall on display. And you can tell by looking at the hand that he created at the start of his career and comparing it to the hand in David that he was able to produce later, that his appreciation for how the body is built was clearly informed by dissection. So I have spent over a decade with my hands on my patients, injecting knots, feeling them release, watching how tension moves throughout the body, and comparing that with what I had learned traveling the world 20 years ago about acupuncture and chakras and the healing traditions of Asia. And so what we now understand as myofascial chains, this is from a book called Anatomy Trains, written by Tom Myers, which has become a Bible in rehabilitation medicine. We can see that those lines of fascia mimic the lines that were drawn centuries ago to describe what the Chinese called acupuncture meridians. So these channels, whatever they are, were said to extend proximally to the spine from the fingers and toes. And the notion that the arm and the leg each had their own sets of channels was confusing to Western medicine. The notion that these meridians existed was really hard to reconcile with the dissection that they were doing. So they dismissed them as fanciful ideas that made no sense. But if we recognize that these reflect lines of tension, and we understand that fascia, this tissue that we cut away in medical school to get to the structures we wanted to look at, is actually the source of the movement that we see every day. The reason that the knee moves the lower leg and the upper leg the way that it does, and that when we twist at the hip, the shoulder moves with it. And the fascinating thing is that these channels were named after organs, and nobody had any idea why. But when you recognize that the arm channels and the leg channels will meet in the center of the body, and that these long strips of fascia would not just continue from the pelvis to the thoracic cage, but they would wrap around organs on their way through that tunnel, it reveals a level of structure that's simple and clear. And if you look at the body in cross section, this is the leg, you'll see a radial symmetry that comes from the center of the extremity. And if you imagine that these are 6 slices of flesh, like slices of a pie, with 3 on the inside and 3 on the outside, pulling and twisting on each other, it reveals a spiral anatomy based on a 6-sided twisting scaffold with 6 slices of fascia connecting long chains made of singular muscles held together from beginning to end. And this map that shows you the 6 channels of the arm on the left, and on the right, you see the 3 outer channels and the 3 inner channels on that last diagram of the leg. The concept of yin and yang gets turned into pushing and pulling, internal rotation and external rotation, expansion and contraction. And so when we look at Michelangelo's David, we see a scaffold building on a 6-sided radial structure with a central line traveling down the middle so that they rotate around it. And we also see the same structure at every level. In the wrist, we see that the thenar and hypothenar eminence can twist back and forth on each other. And if we recognize that these 6 chains of the arms and the 6 chains of the legs attach to the cranium and the torso and the pelvis, we start to see a blueprint for how the body is built that is simple and repeatable. And when you look at 3 scalene muscles twisting the thoracic cage through 3 different parts of a range of movement, and you see 3 layers of oblique muscles at slightly different angles twisting the torso through the range of motion by shifting tension from one acupuncture channel to the next, to the next. And you see the same pattern in the design of the oblique muscles from the deepest to the middle to the outer layer. Slightly different angles of rotation, moving the body through different parts of the range that it has to go through, shifting tension from one channel to the next, to the next. And if we look at anatomy, we see clear evidence that the scapula is built to pull on the opposite pelvis, and that force is transmitted through the ribs, acting like an accordion, allowing not just twisting left to right, but expansion and contraction with side bending. And if you look at the small muscles that hold the spine together, you can see this diagonal structural pattern that allows those forces to be transmitted in a twisting manner through the spine, from right to left, from front to back, from top to bottom. And then the final insight comes from the recognition that these acupuncture channels are in fact paired structures. And they're not 2 channels that are symmetrical. They're 1 channel with a butterfly-like design that crosses the midline at multiple levels, and at the levels that crossover occurs, allowing twisting movement to take place. That twisting movement seen from above is what we would call a wheel in Sanskrit, and that's the term for chakra. So this picture of anatomy is very different, but it highlights how a scar in any part of the chain could distort alignment throughout the chain and create problems remote from the injury. So thinking about what kinds of injuries might create these lesions in a surgical patient requires you to think beyond the scar. And recognizing that the scar and the nerves in the area can be pulling and tugging on all of the scars that have ever been in that patient allows you to create a map to connect the current problem to the patient's unique history. Whether it's fractures or dislocations, sprains or strains, whether it's a medical or dental procedure that left scar tissue behind, including skin biopsies, removal of skin lesions, some traumatic punctures, insect bites, animal bites, nail punctures, blunt trauma, and minor wounds that include tonsils and adenoids. Wounds that we take for granted as once and done, like episiotomies, vaginal tears, epidural injections, vasectomy procedures, uh, fingernails, toenails, fractures of extremities, and then wounds that are high risk because they're infected, or because they were not treated promptly, or because they didn't heal quickly, or because the patient was stressed or compromised at the time, or because there were new symptoms that appeared after the event took place. These are things that we think of when taking a history of potential blockages. And again, just reflecting on how blockages can cause disease, looking at the really fundamental forces that shape human illness. We think of these points of stress in the autonomic nervous system as hotspots in your physiology, producing electrical noise. We think about how they control lymphatic drainage, blood flow, and tissue tension. And we think about how all of those can affect the flow of fluids and deliver nutrients, remove wastes, and how that affects the health of cells. We also recognize that because these are areas that are tight, muscles are being pulled physically in space. So even a very subtle shift in the alignment of the tibia and the fibula can have a dramatic difference in the forces that the knee is exposed to every time you run. And this can also affect power and strength and coordination, no matter what your sport. But of course, the links between chronic stress and cardiovascular disease and autoimmune disease and chronic inflammation, and how all of that is linked to hormone imbalances. You start to get vertigo when you think about the potential implications of this hypothesis, if it's true. So I've distilled years of work into a simple technique that anyone can learn to do. I'm targeting providers, but we're also creating content to teach patients how to find and release the unique points of tension and how to connect two dots to create a line of tension along a myofascial chain, and how that unique map of lines of tension creates a logical framework for delivering personalized medicine. So again, what I teach integrates movement and touch, breath and awareness. Under the movement category, what is taught is to keep kinetic chains under tension, to rotate through an arc to identify the affected chain, and to find two connected points, engaging the points in an assisted stretch, in tension, and release. Of course, we use touch to find these points using the technique I described earlier. We use breath because all of the myofascial chains are tethered to the diaphragm. The leg chains from below and the arm chains through the thorax. And so when you inhale, you create tension in the diaphragm and in the myofascial network. So the assisted stretch takes place when the patient inhales, and the release is palpable when they exhale. And then the final ingredient is awareness. And interestingly, the NIH is taking a real shine to this concept of learning to feel what's going on in your body. The term for this is interoception. And there's good data that people with chronic pain are more able to feel what's going on in their body because it's drawing their attention, but they're way worse at localizing where it's coming from because of the emotional context. You know, it's unpleasant, there's resistance. So learning to pay attention to what you feel is what we would consider the science of intuition. And in order to do it, you have to pay attention not to what you're thinking or planning or where you're going or any other unconnected thing, but to focus on what you feel. So single point awareness is good for the brain, whether you're a provider or a patient doing it to yourself. And learning to follow the stress response when you feel it is not difficult. What's really interesting is, depending on how much anatomy you know and how long you've been doing this, you can begin to visualize structures under the skin. And that visualization exercise has been shown to improve results in many disciplines, including sport. So, closing message. Everyone in the rehabilitation sciences is now looking at fascia. We recognize that it's a tensegrity structural network, but it's also part of the nervous system. And what this implies is that there's a new structural framework for human anatomy. And there's a new way to understand persistent pain and disease. The idea that chronic pain occurs for a reason. Yes, of course, sensitized nervous systems, learned behaviors, cultural beliefs, kinesiophobia, catastrophizing, all of these are factors. But if there's a lesion causing pain that medicine has missed, surely this is something that has the potential to be a missing link. And if in fact these interference fields, these Störfeld, these blockages exist, then these pathologic lesions are unknown to medicine. And what a great new adventure. And the really interesting thing that I'd like to see validated is the structural blueprint that links tension to meridians that distribute tension to enable movement, and that allow us to see the structure of the human body in an entirely new way that is simple and beautiful and elegant. And that these points of tension would create a unique body map for each patient. So, you know, this is a really feel-good image of the Gaia mother. And it shows you the Americas, because we are now part of a Pan-American network of neural therapy that we're proud to belong to and looking forward to cultivate. So the vision for blockage-based care is that surgeons will recognize and either treat or refer patients who are at risk of poor outcomes and chronic pain, and that pain providers and other injection providers will augment their current protocols by using palpation to target these lesions in an approach I call palpation-guided neural therapy. And that manual medicine providers can work with us to treat the same lesions we treat by feeling what we feel. And in some cases, in most cases, manual medicine providers who recognize where a problem is connected to a previous problem can take care of that patient. But if we're collaborating with them, we should be treating the same lesions. So injectors and manual medicine providers should collaborate on these patients whenever possible. And the beautiful thing is that patients can learn to feel the lines of tension in their own bodies, building awareness, which will have a synergistic effect on any benefit that is accrued by treating their blockages. And just knowing that there's something that you can do to manage your pain, to take care of yourself, that's logical, that's unique to you, gives you a sense of autonomy and allows you to overcome mentally, emotionally the burden of your illness. So the benefits to your overall well-being seem clear. I'm going to get off my pulpit now and encourage you to go to our website. NAANT is the North American Academy of Neurotherapy, nant.org. Scroll to the bottom of the homepage and just subscribe to our mailing list. Stay tuned for more news to come. And I want to give a big thanks to my team who's been helping me put together data validation websites, this workshop, this webinar, all of it. I couldn't do it without you. Thank you very much. And with that, I will stop sharing. So if anyone has any questions, feel free to send them in the chat. But if you think of them later, feel free to send them to me directly or to the email that you have. And I'll be providing information about workshops soon. I'll be spreading the word with webinars and emails, and I'm grateful for your time and attention. Will a herniated disc affect fascial tension? It's a chicken and egg question. There are some herniated discs which are not really reversible. Whether there's an annular tear, like a tear in the wall of it, or whether it's a disc extrusion with some of the jelly that leaks out into the space, very pro-inflammatory problem. But in most cases, when you're seeing a herniated disc, what you're actually seeing is an imbalance in the tension and direction of the muscles that hold the spine in alignment, creating a weakness at one side. And that may, in some cases, include the ligaments that wrap around the vertebral bodies. So there are many cases of herniated discs that disappear on imaging with treatment. And that's a worthwhile thing to pursue, but it depends on the herniation. Some need surgery. Could you comment which myofascial networks are affected in patients with common scars like C-section, mastectomy, cardiac bypass? Well, I mean, that's a big question, but it's a great question. I'll start with the C-section scar. It's important to remember that the pelvis is a bowl. And so that is a three-dimensional structure that shifts tension from the front to the back, from the right to the left, from the upper pelvis to the lower pelvis. So the way to address the pelvis is to consider the C-section scar with all of the other scars that have taken place in the pelvis. Because any of the leg channels can be affected by the pelvis, but generally speaking, there are inner channels and there are outer channels. The outer channels they call yang, and they're more responsible for external rotation. So they're more on the lateral aspect of the torso. The inner channels, which are involved in internal rotation on the inner leg from the medial ankle, the base of the sole of the foot, up the inner calf into the adductors, traveling up to the midline of the body where the C-section scar is, are more likely to be affected by that scar. A mastectomy is obviously more likely to affect any of the arm channels, but depending on how the procedure is done, it may also affect leg channels, because the legs are tethered to the thoracic cage. And when you run, you twist from the scapula and you move the torso. So I think one of the reasons that the torso has a higher incidence of complications is because the torso is one of the places where the arm channels and the leg channels intersect. Similar to the traps at the back. That's a very common area of tension in the body, because that's where the arms and the legs overlap. In fact, you'll have a layer of arm tissue and leg tissue and arm tissue and leg tissue, and they're woven into each other to maintain structural integrity. But the really interesting thing is that the cardiac bypass scar is one end of a line of tension, and the direction that it's going to travel depends on where the other injury was. If one patient had a humerus fracture, then that would travel this way. If another patient had an appendix surgery, it might travel down the abdomen. If a different patient had rib fractures on the right, it would wrap around the torso and cause mid-back pain. So thinking about pain syndromes, not in terms of a point, but in terms of 2 points that pull on each other, creating a line, is the way to shift your thinking from points to lines. And the lines are usually connected by 2 scars. And those are 2 knots that pull on each other. Very simple physical concept. So that was great. Thank you very much. Have a great evening. We'll see you next time.